Good afternoon, everyone. Happy Saturday. Welcome back to Pathagonia. Just wanted to do another episode. I'm going into my last week of my GYN rotation in residency, and this week we're gonna talk about mesenchymal tumors. So I just kind of wanted to do this video as a primer for that. I am on call, so if I get paged, I will resume the video after. But let's get started. So mesenchymal tumors of the uterus. One category of mesenchymal tumors that's common in the uterus is smooth muscle tumors. So those are going to stain with IHC. They're going to stain positive for desmin, SMA, H-caldesmin, ER, and PR. The classic example of a smooth muscle tumor is going to be a leiomyoma or fibroid uterus, very common specimen on surgical pathology. So a leiomyoma is a benign smooth muscle tumor. It is the most common uterine tumor, and it can present with pain, bleeding. Grossly, it's going to have this white, firm, whorled appearance with often multiple well-circumscribed lesions like this, and uterus can be very distorted from all of these leiomyomas. Usually there's bundles of bland spindle cells arranged in intersecting fascicles microscopically. You can see cigar-like nuclei with fine chromatin, and molecular for a lyo is going to be a MED12 mutation or HMAG1 or 2 rearrangement. So you're allowed to see infarct type necrosis, which has a band of granulation tissue with or without hemorrhage and fibrosis between viable and non-viable mummified or hyalinized tumor, which is different than tumor type necrosis. So there are some variants of leiomyoma that you can have. You can have a cellular leiomyoma, which has significantly increased cellularity, as the name suggests, compared to the normal myometrium, but only rare mitoses and no atypia. You can have leiomyoma with bizarre nuclei or symplastic. And here's a good example of a very bizarre nuclei that would catch your eye when you're previewing. It's going to be smudged, hyperchromatic, pleomorphic, but no mites or necrosis. You can also have a mitotically active leiomyoma with mitoses but no atypia or necrosis. You can have a lipoleiomyoma, which contains mature adipocytes, a myxoid leiomyoma containing hypocellular myxoid stroma, epithelioid leiomyoma containing round polygonal cells, as demonstrated here in this image. You can also have a cotyledonoid or dissecting leiomyoma with irregular nodular dissecting bands of smooth muscle cells within the myometrium, and diffuse leiomatosis, where you have innumerable poorly circumscribed hypercellular tumor nodules, as well as intravenous leiomatosis, which is intravascular growth outside the tumor, and metastasizing leiomyoma. So a benign appearing extrauterine leiomyoma and a patient with uterine leiomyomas. Usually you'll see this in the lung. And if there's tons, particularly at a young age, you might want to consider hereditary leiomyomatosis and renal cell carcinoma syndrome. Classically, these have staghorn vessels, eosinophilic nucleoli with halos, as seen here. And then more atypia, edema, and rhabdoid inclusions, which are shown with the red arrows, the rhabdoid inclusions. And that hereditary leiomyomatosis and renal cell carcinoma syndrome is going to show loss of fumarate hydratase and gain of 2SC. Next up, we've got leiomyosarcoma, which is the malignant variant of a leiomyoma. It's a malignant smooth muscle tumor, usually occurring in older patients, typically spindle cells, but can be epithelioid or myxoid you're going to see abundant mitoses, necrosis, or atypia, frequent atypical mitoses, genetically complex chromosomal aberrations, and leiomyosarcomas typically have a very poor prognosis. So the diagnostic criteria of a leiomyosarcoma varies by subtype. So for conventional, you want at least 2 of the following: marked cytologic atypia, increased mites, meaning more than 10 mites per 10 high-powered fields. Here's a good example of mites that you may see. And then tumor type necrosis. Not the infarct type necrosis we talked about earlier, which is allowed, but the tumor type necrosis, which is going to show coagulative tumor cell necrosis with a sharp interface between viable tumor around feeding vessels and non-viable tumor with noticeable tumor cell ghosts. So over here you see tumor necrosis and viable tumor here. And again, for that to be diagnostic of a leiomyosarcoma, you're going to want to see at least 2 of those 3 for it to be able to make that diagnosis. We're back. Another type of leiomyosarcoma you can have is epithelioid. And for epithelioid, you're going to want to have at least 1 of the following: moderate to severe cytologic atypia, increased mitoses, so greater than or equal to 4 mites per 10 high-powered fields, and tumor type necrosis. So we're seeing a pattern here, right? Atypia, mites, tumor type necrosis. And for a myxoid leiomyosarcoma, you need at least 1 of the following: moderate to severe cytologic atypia, increased mites, just more than 1 mite per 10 high-powered fields, tumor type necrosis, or infiltrative borders with irregular margins. Given the low bar for malignancy, be sure to sample myxoid smooth muscle tumors particularly well. And another kind of a cool category is a smooth muscle tumor of uncertain malignant potential, or a STUMP. So this is a smooth muscle tumor whose features preclude a definitive diagnosis of a leiomyoma and a leiomyosarcoma. There's often equivocal mitoses or necrosis with a relatively low risk of recurrence. And many IMTs were previously mistakenly diagnosed as this, so consider doing an ALK IHC. And we'll get to what the IMT is shortly. So the endometrial stromal tumors is the next category, leaving smooth muscle land. So these are low-grade or benign tumors that stain like normal endometrial stroma with CD10 and ER and PR, and high-grade stains with cyclin D1. So this is an endometrial stromal nodule, which has a benign tumor. It is a benign tumor resembling proliferative endometrial stroma with a relatively well-circumscribed margin, and there's no LVI, so there's no lymphovascular invasion, and it's very well circumscribed. You're going to see uniform small cells with scant cytoplasm and round and oval nuclei, and molecular frequent is the JAZ-F1 SUS12, or I've heard it referred to as Jazzy Sus or Jazzy Susie, which is the same as a low-grade endometrial stromal sarcoma, which we're about to talk about now. So well circumscribed is like the first of this variant. I think of it as a spectrum, going from stromal nodule to low-grade to high-grade, and this endometrial stromal nodule is, as the name suggests, well circumscribed or nodular. However, once you start seeing this tongue-like growth, which you can think of a tongue here, these little tongues protruding, you might want to think about a low-grade endometrial stromal sarcoma, which is a malignant tumor composed of cells resembling proliferative endometrial stroma with an infiltrative or permeative growth into the myometrium with or without the lymphovascular invasion. And as mentioned, they often have that tongue-like growth, uniform cells with scant cytoplasm, fusiform nuclei, no atypia, and they can have some smooth muscle and or sex cord differentiation. And the molecular is going to be the same as the endometrial stromal nodule, JAZ-F1 SUS12, think Jazzy Susie. And low grade has an intermediate prognosis, mostly depending on stage. Moving on the spectrum a little bit further, we have high grade endometrial stromal sarcoma. So as the name suggests, you're going to see high grade round cells, and this of course is a malignant tumor derived from endometrial stromal cells. And you see this high grade nuclei and or spindle cell morphology. These are frequently myxoid, typically confluent, permeative, destructive growth, and they usually have a high mitotic activity, necrosis, and LVI. And they can have a low grade endometrial stromal sarcoma-like areas. And this molecular is unique. It's YWHAE, NUTM2A or B fusion, or a B core alteration. And these are more aggressive, no surprise, as they're high-grade endometrial stromal sarcoma. And then just for your own review, I'm not going to go through the table. Here's an IHC table for the endometrial stromal nodule, and then the various entities that have a different molecular background that we've already discussed. So some other mesenchymal entities, you can have an undifferentiated uterine sarcoma, which is a malignant tumor arising in the endomyometrium with high-grade cytologic atypia and no specific line of differentiation. So undifferentiated, no specific line of differentiation. Destructive invasion, marked cytologic atypia and brisk mitotic activity. And this is actually a diagnosis of exclusion. So you must rule out a carc-sarc or a carcinosarcoma, an LMS, or an endometrial stromal sarcoma, and other entities. For IHC, for an undifferentiated uterine sarcoma, it's going to be variable with negative IHC for most specific markers. Complex genetics, and most patients present at a high stage with a poor prognosis. Next up, we have uterine tumor resembling ovarian sex cord tumor. I have definitely missed questions on this entity, so good for me to review. This is neoplasms resembling ovarian sex cord tumors without a recognizable endometrial stromal component. So they're usually well circumscribed with minimal atypia or mites, sheets of cords, trabeculae, and or tubules. There can be scant to abundant eosinophilic cytoplasm, and for IHC, frequently WT1 positivity with variable expression of our sex cord markers, which are inhibin, calretinin, and melin A. There's recurrent NCOA translocations for the uterine tumor resembling ovarian sex cord tumor, and these typically have a benign course. So this is a kind of a tough one for me, so good one to review and be aware of. Next up, we've got rhabdomyosarcoma, which is a malignant tumor showing skeletal muscle differentiation like a rhabdomyosarcoma elsewhere. And the IHC is going to be positive for myogenin, myod1, or desmin. Next up, we've got a PEComa, or perivascular epithelioid cell tumor. This is a mesenchymal tumor containing epithelioid to spindled cells with clear to eosinophilic granular cytoplasm, demonstrating melanocytic and smooth muscle differentiation, thought to be derived from so-called perivascular epithelioid cells, hence the name, perivascular epithelioid cell tumor. For IHC, it's going to stain positive for HMB45, melin A, and or cathepsin K, with variable smooth muscle markers, SMA, desmin, caldesmin. And the molecular is going to have a TSC mutation or a TFE3 fusion. Some features to evaluate for malignancy in a PEComa is greater than or equal to 5 centimeters, high-grade atypia, more than 1 mite per 50 high-powered fields, necrosis, LVI, or infiltration. And that's not anything unique to picomas, right? Those are all high-grade features that would make us think of malignancy basically in any neoplasm. So if there's less than 3 benign or uncertain malignant potential, and less than 3 of those features that we just talked about, or if there's 3 or more, you would consider that potentially to be a malignant picoma. So the IMT that we referred to earlier in the stump category is the inflammatory myofibroblastic tumor. And this is going to be bland spindled myofibroblastic cells growing in fascicles with prominent inflammation, usually lymphoplasmacytic, often have a myxoid stroma, and they're going to be positive for ALK or ALK. So variable for smooth muscle markers, and they're going to have ALK rearrangements molecularly. So if you're in the stump category and there's much inflammation, you might want to consider doing an ALK IHC just to rule out an inflammatory myofibroblastic tumor. They're usually benign, but features that predict aggressive behavior, not uncommon, are size greater than 7 centimeters, necrosis, severe cytologic atypia, mitoses, and LVI. Next up, we've got in-trech rearranged spindle cell neoplasm. This usually occurs in the cervical stroma of younger women with uniform spindled cells with variable architecture, often mitotically active, and sometimes with lymphocytic infiltrate. The IHC is going to be positive for CD34, S100, TRK, cyclin D1, and positive molecular in-trech rearrangements. So next up, we'll go into some tumors with an epithelial and / mesothelial component. First up, so this is an instant pattern recognition type entity, and it's an adenomatoid tumor. So you're going to have, it's a benign tumor of mesothelial origin, and you're going to have interanastomosing pseudoglands with variably sized tubules, sometimes with a signet ring appearance, and slit-like spaces with associated smooth muscle hypertrophy, so it can be mistaken for a mesenchymal tumor. A helpful feature is this thread-like bridging strands, and for IHC, tumor cells will express cytokeratin AE1, AE3, and mesothelial markers, which are going to be D240, WT1, and calretinin. And BAP1 is going to be intact, because remember, if we lose BAP1, that's going to make us think of a malignant mesothelioma. And for an adenomatoid tumor, the molecular is going to be a TRAF7 or TRAF7 missense mutation. Along the same category, we have an adenomyoma, which is a benign nodule or polyp composed of endometrioid glands, seen here at number 1, endometrial stroma at 2, and smooth muscle at 3. So this is essentially adenomyosis plus a leiomyoma. So you can think of it as like a well-circumscribed adenomyosis. Next up, we've got carcinosarcoma. So this is a cool entity. It's a biphasic tumor with a malignant carcinomatous and sarcomatous element. So we can see the carcinoma here, the epithelioid malignancy, and then you can see the sarcoma as well. So that's why it's biphasic. There's 2 different lines of malignant cell types. Carc-sarcs or carcinosarcomas usually occur in older women with a mass prolapsing out of the cervix, often have advanced stage and poor prognosis, sadly. So for the carcinoma element, it's often serous, sometimes endometrioid, and for sarcoma, it's often high-grade, non-specific sarcoma, but can make heterologous elements such as an osteosarcoma, chondrosarcoma, or rhabdosarcoma. And an example of an epithelial to mesenchymal transition, transdifferentiation of carcinoma to sarcoma, and the molecular for a carc-sarc is often TP53 mutations. Next up, we've got adenosarcoma. So this is a mixed epithelial and mesenchymal tumor with a benign epithelial component and malignant stroma. Often protrude out of the cervical os, and you want to think at low power, you may look at this and be like, oh wow, that looks a lot like a phylloides or a phyllodes tumor. You're going to see these broad leaf-like polypoid projections of stroma, stroma condensation or cuffing around glands. And you can show heterologous elements and sarcomatous overgrowth in these, just like you would see in like a malignant phylloides. And for IHC, for an adenosarcoma, the stroma stains with CD10, ER, and PR. And this is a low-grade malignancy with an often favorable outcome. And that's it. We made it to the end of the mesenchymal tumors of the uterus. So I hope you enjoyed, and I hope you have a good rest of your weekend. And thanks for listening.